Hello, and welcome to our webinar today on LSVT LOUD in pediatric motor speech disorders. I am Cynthia Fox, and I'm excited to be joined by my colleague, Dr. Carol Bolick, and we will be your presenting faculty for the webinar today. Let me give you just a little bit of a plan for what will happen with the webinar. You should have been emailed a handout of the slides prior to the webinar beginning. If not, there's actually the ability to download those slides as an attachment in the webinar menu. Our goal will be, once we get through a few logistics, is to discuss the application of LSVT LOUD to pediatric motor speech disorders with a focus on children with cerebral palsy and children with Down syndrome. There will be opportunities to ask questions, and we certainly encourage your participation. At any time during the webinar, you can type in a question, and then at the very end, there'll be the ability to type in questions or actually raise your hand and ask your question live. We will leave a few minutes at the end for questions, but also recognize after the 60-minute presentation is over, Dr. Bullock and I will stay on the line a bit longer to be sure that all questions are answered. At the end of the survey, when you decide to end, and you don't have to stay past the 60 minutes if you need to end, only if you'd like to for those additional questions. There will be a short survey that launches. It takes less than 5 minutes to complete, but it provides us valuable feedback. So if you're able to take a few moments to answer that survey, we would appreciate it. Some information to self-report activity. The LSVT Global webinar is not ASHA or state registered. However, it may be used for self-reported CEU credit or a non-registered CE activity. So if you are a speech, physical, or occupational therapist and would like to use this for a self-report activity, simply email webinars@lsvtglobal.com at the conclusion of the webinar to request a certificate. A little bit about myself. I am a speech language pathologist. I've been affiliated with LSVT LOUD for over 20 years and was one of the first to take the application beyond Parkinson's disease to pediatric motor speech disorders. And that was done in collaboration with my colleague, Dr. Carol Bolick, who is currently a professor in the Department of Communication Sciences and Disorders at the University of Alberta. At the time we began our collaboration, however, she was at the University of Arizona, where I was. So the two of us together have spent 15 years now in the pediatric application of LSVT LOUD that you'll hear about today. A few quick disclosures. All faculty have non-financial and financial relationships. Non-financial is a preference for the treatment technique LSVT LOUD. In terms of financial, I'm an employee of, co-founder of LSVT Global, and I receive honorarium and I have a financial interest in the company. And Dr. Bullock receives honorarium and travel reimbursement from LSVT Global. This work was funded in part by several organizations, the Cerebral Palsy International Research Foundation, LSVT Global, Stollery Children's Hospital Foundation, Edmonton Oilers Community Foundation, and the National Institutes of Health. And of course, without that funding, we would not be able to have completed the exciting work that we'll share with you here today. Our objectives are to present the rationale for intensive voice treatment in children who have motor speech disorders, again, secondary to cerebral palsy or Down syndrome. We'll discuss some phase 1 research discovery, and we'll present LSVT LOUD treatment protocol with some audio and actually one video example. Then we'll follow up by explaining our phase 2 discovery and research findings. Before we go any further, we'd like to know a little bit about who's in the audience. So I'm going to launch an interactive poll. And now you should be able to interact with the questions you see here. Are you an LSVT LOUD certified clinician? A non-LSVT LOUD speech language pathologist, allied health, family member, or other. So we'll give just a few moments for everyone to respond. Okay, and so it looks like we have mostly speech language pathologists. Now, some people may have not voted, but we've got a nice mix of those of you who already know about LSVT LOUD and some speech language pathologists who may not be LSVT LOUD certified, but are interested in learning about LSVT in pediatric populations. So again, welcome to everyone. Let's see if I'll get back to the slides. Perfect. So as we all know, given we have a primarily speech-language pathology audience, communication is so important. And what Dr. Bullock and I have learned from our work, and this has come from a lot of interviews with both children and parents of either children with Down syndrome or cerebral palsy, that these kids want to be socially accepted. So their first choice is to use oral communication. And in fact, many of these kids continue to communicate orally, even in the absence of success. And they get very frustrated when peers or adults fail to wait to understand the message, try to answer for them, or simply walk away. So there's a great need for us to be able to help improve communication in this population. Now, our work with LSVT LOUD, for those of you who may not be as familiar with it, began in Parkinson disease. So what in the world made us think a Parkinson treatment in a neurodegenerative adult population would have any application to a neurodevelopmental condition such as cerebral palsy or Down syndrome? Well, this actually began when Dr. Bullock and I were together at the University of Arizona. She was a professor working with children with cerebral palsy, looking at respiratory patterns, and I was a doctoral student. And we had some nice conversations about challenges these children have with communication, respiratory support, vocal loudness, and we simply thought, what if? And so oftentimes the first phase in science is that curiosity, and so we simply did a case study. And our first little guy was 3 years, 11 months old. He had a dyskinetic type of cerebral palsy. Normal cognitive development, but delayed language development, very, very motivated to communicate. And he had voice and speech characteristics that made sense to focus on the voice as a target, in that he had throaty and strained talking, limited respiratory supports, breathy sometimes. He was variable in vocal loudness, severely reduced intelligibility, and sometimes either strained or breathy vocal quality. So a dyskinetic type of, sometimes loud, sometimes not loud, sometimes strained, sometimes breathy. So this is an audio sample of him saying this sentence, "I don't know," pre-treatment. And on top you have the microphone signal with the spectrogram below. I'll play it one more time. Oops, or I won't. Here's post-treatment.
I don't know.
So I think you can appreciate the types of changes that we heard in his communication after the 1 month of LSVT LOUD treatment. He had improved stability of phonation, increased frequency of voice and speaking. So he initiated more speaking, both at home as well as outside of the home. It was not so breathy, not so strangled. And as his mother said, he really understands what using his voice is and what that means in terms of making himself heard and understood, and definitely increased his confidence with speaking. So based upon that first case study, I'll turn it over to Dr. Bullock now, who will take us through our next step of thinking through a greater rationale. So Dr. Bullock?
Great, thanks, Dr. Fox, and I want to say my own welcome to everyone out there. It's a pleasure to be a part of this webinar today. So I'm going to take you through sort of our next steps of thinking with what we saw with the case study, and where do we take it next? What kinds of things could we do in terms of this type of treatment with kids who have cerebral palsy or kids who have Down syndrome and motor speech disorder? So I'm going to walk you through our motivation as well as our rationale. Next. So first of all is What do we target? What system in the speech mechanism do we target? And we decided to look at voice. So why voice? Next. So when we think about what these children present with, we can look at the perceptual characteristics, some of which we saw in our initial case study. And that is that children with cerebral palsy or Down syndrome may show hypernasality, breathy voice quality changes. Sometimes they're monotonous in terms of their pitch. They often present with uncontrolled rate and rhythm of the voice and imprecise articulation. So if you look through this list, you see a lot of things target or seem to focus on voice. Next. So we decided to look at the target of voice, and we thought maybe voice would be a good point of entry into the speech mechanism. And that's not the first time this has been talked about. Edie Strand in 1995 said, you know, it's really important to establish a phonation foundation through training the respiratory and phonatory systems, and that provides the foundation for downstream events like resonance and articulation. Next. So once we decided, okay, we'll stick with the target of healthy vocal loudness, what is our mode of treatment going to be? Will it be intensive, not intensive? Will it require high effort? And so we decided to focus on intensive and high effort modes of treatment. Why did we decide to do that? Well, next slide will show that treatment-dependent neuroplasticity, or what we mean by treatment-dependent neuroplasticity, is treatment-dependent change occurs, especially in the pediatric context, when we have intensive task repetitions, so lots of repetitions, progressive challenges to the learner with increased difficulty, which we often forget about, that the need for challenges, the need to tax the system is very important to make these kinds of changes. Also, the presence of motivators and rewards, and keep in mind that we're talking about those that are internally driven. So when a child sees that they're communicating, they feel what they feel, they see what can happen when they're understood, requires some internal motivation to do that again. Also, active participation by the child, skill acquisition with a functional goal. So does the goal pertain to the child? Does it have saliency for the child in their communication environment? And then practice must be structured. Next. So when we think about efficacious approaches to overall rehabilitation in children, we found ourselves turning to physical therapy for some advice and some wisdom. And we know from the physical therapy literature that children with CP, which is the panel on the left, they benefit from treatment programs with intensive frameworks. So this would be based on limb literature. They also benefit from a number of sessions, not just one or two, but many sessions. That if we target specific targets, if we have specificity in our targets, then we see bigger results and better results. And increasing the task difficulty matters both in physical therapy and, as I think you'll see, in speech therapy. Same with Down syndrome. So benefits of treatment occur when you have treatment happening more than once per week. And children with Down syndrome also can handle intensive physical difficulty during interventions. Next slide. So what about speech treatment? Well, as you may know, there are very few approaches to look at that are systematic, and mostly what we find in the literature and find in practice are traditional approaches to speech treatment for children with motor speech disorders. And that means that we might take a single target in a single subsystem or multiple targets that would cover respiration, phonation, articulation, and resonance. And so the other thing that we typically do is somewhat low to moderate in intensity, meaning we see children maybe once a week if we're lucky, low repetitions of a task, and limited focus on effort. And so when you look at the literature based on our traditional approaches to treatment, we see limited efficacy in the outcomes. Next slide. So when we think about best practices for pediatric motor speech disorders, the majority of speech language pathologists agree, those who are specializing in pediatric motor speech disorders, they agree that intensive motor speech treatment, regardless of subsystems targeted, is preferable as a mode of treatment delivery. Next slide. So why LSVT LOUD versus some other form of treatment that could also target voice? Well, LSVT LOUD is, as you know, an established treatment approach. And the alternative that Cynthia and I could do would be to develop a new treatment protocol. And that's very difficult and may or may not have good outcomes. So why not take something we know has good outcomes in another population and see if we can apply it to the pediatric population. Next slide. So just to go back a little ways, as Dr. Fox mentioned earlier, there's been a 25+ year journey from invention of LSVT to a scale up to prove at phase 4 and 5, not only clinical efficacy, but clinical effectiveness. And you can see here where we've plugged in a little yellow arrow where the pediatric work started, again, 15 to 18 years ago. So we've been moving forward slowly, but based on all of the progress that was previously done using LSVT, particularly with individuals with Parkinson disease. Next slide. So the idea of targeting loudness is that we're basically providing a source for sound production that triggers distributed effects across the speech mechanism, including respiration, including articulation and resonance. So by having a single target, a treatment target of healthy vocal loudness, we also limit the cognitive load and at the same time encourage this distributed effect across the entire speech mechanism, as indicated with this cartoon here. Next slide. So the training mode, now that we've established that we're going to hit the voice system, a single target of healthy vocal loudness, the mode of LSVT LOUD follows the principles of activity-dependent neuroplasticity that I showed you before. So treatment in this case is delivered 4 consecutive days a week for 4 weeks. So those of you who are certified in LSVT LOUD, you'll see that we have not changed the dose at all in terms of the mode. Each session is an individual session of 1 hour with many, many repetitions. Daily homework practice every day, all 30 days of the month, and daily carryover exercises which pertain to doing the skilled communication in various activities outside of the clinic room. And our hope is to develop a lifelong habit of practice, which will then feed into long-term changes, and we hope long-term neural changes as well. Next slide. So the focus is on function in LSVT LOUD. We use the idea of high saliency or high meaningfulness with these children so that they're highly motivated to work hard, to learn the new skill of healthy vocal loudness and immediately see its impact on daily function. So saliency, meaningfulness of the treatment targets and the carryover activities. Functional phrases are determined by the child and the family, and those are phrases that children use every single day in their communication environment. The progressive hierarchy is a way to move beyond the treatment targets into communication events, either those that are related to school, related to home, related to social activities, and carryover activities, which again take the skills focused on in treatment to the communication environment outside the clinical setting. Underneath all of this is calibration, and that's an internal calibration that the child establishes so that when they communicate, they automatically use their new healthy vocal loudness, and trying to get to the point where these children don't need an external cue as a reminder to use their new skill. Next slide. So I'll turn it back over to Dr. Fox, who will talk about the first of the number of studies that we initiated to begin to establish therapeutic and clinical efficacy. Dr. Fox?
Thank you. So our first point of entry in research really followed the Roby and Schultz guidelines for clinical efficacy studies. And that phase 1 really is about discovery. And our goal here is to detect the presence of a therapeutic effect, define the population, the protocol, the dosage, and typically single case design, small groups are what are used. There's not controls, there's not comparative treatments, and not necessarily blinding at this phase of research. And that's certainly what we embarked upon in this phase of trying to detect the presence of a therapeutic effect, going beyond just our single case study that we presented. So what we did was a single subject, multiple baseline design. Our measures were speech acoustics, listener perceptions, and parent ratings. And we included 5 children with a predominantly spastic type cerebral palsy and dysarthria, ages 5 to 7 years. And you see in these photos here, the setup in the sound booth, we had a consistent mouth to microphone distance. Children were either in their own seating, such as a wheelchair, or this adaptive seating that you see the little girl on the left-hand side has. And we collected data at multiple time points pre, multiple time points post, and after 6 weeks following the end of treatment. What I'm going to play for you now are just a couple samples of the listener perception task. So we'll listen to this little girl, 5 years, 10 months old, who had a mild to moderate dysarthria. You're going to hear 3 repetitions of a sentence pre-treatment, followed by 3 repetitions of that sentence post-treatment.
Pair 6, sample A.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Sample B.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Next, I'll play a sample from a little boy, 7 years, 7 months, who was much more severe. So he could not actually even say the entire sentence. And this sentence was, "Buy Bobby a puppy." So you'll hear him say just the word puppy. Again, 3 repetitions pre, 3 repetitions post.
Sample B.
Poopy, poopy, poopy.
Pair 7, sample A.
Puppy, puppy, puppy.
So that gives you an example of the type of listening task that our listeners did in all of our studies. And of course, we selected samples to prepare for you that were pre-post, but they weren't always in that presented in that manner. Sometimes it was follow-up compared to pre, post compared to follow-up, post compared to pre. So it was mixed up, not labeled, and that listeners were able to judge which samples they preferred. And what we found across our acoustics, our listener data, and our parent ratings were that the greatest improvements in acoustics were in the maximum performance tasks that we trained during treatment. There were strong listener preferences for the treated samples. And I think you can appreciate in the samples that we played here that the children were louder, voice quality was improved, articulation was improved, and these are some of the things that our listeners picked up on. And it had very favorable ratings from parents. And that's key because, as we know, in pediatric populations, family and parent members are key to helping carry over the exercises at home, getting children to the treatment sessions, and they were very supportive of this intensive type of approach. So those data were published in 2012, and you have the reference here on the slide. So back to our initial question in terms of our phases of research, do we detect a therapeutic effect? And I think our answer was definitely a yes. So the next step then is to take the research into more controlled phase 2 small group designs. Oops, my slide jumped ahead of me. But before we go there, I'd like to talk a little bit more specifically about the treatment protocol itself. So most importantly, LSVT LOUD in pediatrics is really a different way of doing therapy from some of those traditional approaches that Dr. Bullock mentioned. And oftentimes kind of knee-jerk questions we get when people are thinking about this is, wow, can you really get a kid to sit and do that full hour intensive session with all of those repetitions? No way can we get these kids to come in 4 days a week. Can children with cerebral palsy really give that much effort? And are there negative consequences to training vocal loudness or high effort? And if we train loudness or stimulate loudness in these kids, are we at risk of vocal hyperfunction? So hopefully we'll answer all of these questions for you as we go through the protocol and the research data presented here today. So it's really important to look at these repetitions and the amount of time that's spent on motor practice in LSVT LOUD treatment, not just for people with Parkinson's, but also in these pediatrics. So some of our key exercises, the long ahs, the high ahs, the low ahs, at a bare minimum, we're doing over 500 repetitions across that 1 month of treatment. And oftentimes it's many more than that. The functional phrases, over 1,600 repetitions. And we've got about 440 minutes of structured reading, or if the children aren't reading, structured speech practice, and over 440 minutes of less structured conversational type of speech practice. All these tasks as well increase in complexity and difficulty across the 4 weeks of treatment, taking into account all of those principles that drive activity-dependent neuroplasticity. So the first exercise, and those of you who are LSVT trained know these very well, but some of you who may be new to LSVT, we have 3 daily exercises. The first one is the long ah, and that's simply take a deep breath, say ah for as long as you can. So a nice ah. With this, we're training respiratory laryngeal coordination. We're working to improve vocal fold adduction so that we have healthy vocal quality, no strain, no hyperfunction. And we see this as a stepping stone for establishing a good voice that we then train into conversational speech. And this slide really highlights that for you. So the ah is not the target of treatment. Rather, it's a tool to facilitate improved loudness, but not the end goal. So you see here the little girl on the left, the exercise of doing the ah, but our treatment goal and the reason we do therapy is that they can take that into functional speech, daily conversation. And of course, we know our kids love to be on the phone, use their smartphones, talking to their family, talking to their friends. That's the heart of the matter in terms of our treatment outcomes. The second exercise are the high-low ahs. So now we're going to say ah and go high in pitch, ah, go low in pitch. The goal here is to improve range of motion in laryngeal muscles like the cricothyroid, improve control of intonation, and to learn to modulate loudness and control loudness. And we oftentimes hear from family and clinicians, well, they can get loud. If they're mad, they'll be heard and they'll be loud. But oftentimes in conversational speech, they're too soft. So there's the inability to really modulate loudness at a healthy, normal loudness level. And that's ultimately the target and goal of LSVT LOUD. Daily exercise 3 are functional phrases. So we have the child, and they may need the parent's help, but it really needs to be phrases that the child absolutely says every day in his or her life. These are some examples from kids in the past. Can I have the iPad? Or almost every child has something related to the iPad or their tablet. I gotta pee, I need help. The I gotta pee one is a nice example where the parent may come in and have written out, I need to use the bathroom, please. And we have to dig in and stop and say, is that what your child says? And maybe, yes, that can be a goal in the hierarchy we work towards, but these functional phrases need to be things absolutely every day your child says. And so we help the parents come to phrases that really are things the child says every day. They practice these phrases 5 times a day at a minimum, every single day of treatment, and also during homework practice. So they really become overlearn so that they become cues or reminders for the child to use this louder voice in their everyday life. So the first 3 exercises, the long ahs, the high-low ahs, and the functional phrases, take up the first 30 minutes of the treatment session for these kids. The entire second half of the treatment session is spent on what we call the speech hierarchy. The goal here is to increase complexity of communication and endurance for maintaining this louder voice for longer and longer periods of times. So as we progress through the weeks of treatment, our length of utterance will increase from single words to short phrases, to sentence length, to paragraph length, to back and forth spontaneous conversational speech. In addition, we're gearing this speech practice both to topics that are salient for the child, and these are examples, a child who loves Disney movie, Disney characters, we'll embed that into our motor practice. We had an older child, she loved reading, and mystery books were her favorite. So we embedded those types of speech exercises for the practice. So not only do we talk about topics that are salient to each child, we also embed their long-term goals. What ultimately do you want to be able to do at the end of the treatment? Is it talk to your friend on the phone or communicate with your teacher? And we'll embed those individual goals. Now, if you have children, like the one little boy I played who went from really had single words, you might be thinking, how do I progress them through the hierarchy? Even if your length of utterance may only go from 1 word to 4-word phrases, you can still work across the weeks of treatment to gradually increase that length of utterance, as well as the types of communicative situations. So in week 4, we may have, again, spontaneous conversation at those short phrases, but you're gonna have background noise, we're gonna have distractors, so that we're increasing complexity even if we tap out in terms of length of utterance. Now what I'd like to do is play a video for you, and this video is of a little girl, looks like it's not gonna do that, who has cerebral palsy. She's in week 4 of treatment, and I'll just give you a little bit of an idea of what treatment looks like. You're gonna see her doing her long ahs, a little bit of functional phrases, and a little bit of a hierarchy task. Oh, perfect, Miss Katie. So what we're gonna do is you're gonna give me a nice big ah, ah. Whoa! What did you get?
I got 953.
Good. Are you ready with your big, beautiful voice?
Yes.
Okay.
Hello, this is Katie.
Perfect.
Good morning. Stop it. Okay. Yes, please.
Don't forget to breathe.
Mom, Dad, come in here. Can I wake up? Stacy. Thank you. Excuse me.
Okay, what if they didn't hear?
Excuse me.
Good. All right, now with your ah, let me hear another little ah. Go ah, ah. Good with that voice. Explain what that is.
This is something you cook with. And it has different buttons that you can push.
Oh, try that again.
It has different buttons that you can push.
Good.
Microwave.
No.
No.
Stove.
Yes.
Woo! Good. Okay, so I know there's a tiny bit of lag between the audio and the video when we present them in the webinar, but I think you could appreciate the exercises and how engaged she was in them, and how she was able to use that louder voice to improve her intelligibility. So finally, as Dr. Bullock mentioned, calibration requires individualization. It requires saliency so that the child really finds a reason to take these treatment techniques and use them in the real world. And these are just examples that it will vary from child to child across families, schools, social activities. One child may be very invested in improving voice for school activities. Another younger child, it might be most important at home, being understood on the phone to talk with friends, just increasing that confidence to initiate and participate in conversations at home and school. And so even though we have a very structured, standardized protocol, the take-home message is that we can individualize the topics we use in speech tasks and our carryover exercises to make it meaningful and salient for each child. So now I'll turn it back over to Dr. Bullock to take you through our phase 2 research.
Thank you, Dr. Fox. So I'm going to explain some of our research findings that I hope I can use to show how we've sort of conquered whether or not we should continue with this research, whether or not these results from our original findings hold up over a number of different groups of children. So that's what I'm going to talk about next. So we call that phase 2. And that's where we define and refine our protocol, look at different outcome variables. We use valid and reliable measurements to assess our outcomes. And we've moved now into some small groups with controls, as you'll see, and some studies without controls still, as part of moving through phase 1 to phase 5 efficacy research. Next slide, please. So this is sort of an overarching table of where we're currently at with our treatment research. And as you can see, Dr. Fox just went through the phase 1 with the single subject multiple baseline design, and you saw heard sounds pre-post from that study. So we did see positive effects in our parent ratings, listener perception, as well as some acoustic measures based on those treatment effects. We then went on to a phase 1 pre-post study with a group of Down syndrome individuals, and those children were ages 4 to 8 years. There were 9 of those, and we essentially used the same outcomes that we did in the original study, and then moved into some larger studies with comparative, typically developing children, as you can see in the last 2 rows there, 9 children in each of those groups, and we looked at all of the same outcome variables, but we also looked at some physiological measurements as well as neuroimaging measurements to see if we were also able to detect changes in the respiratory and laryngeal subsystems as well as in the brain. Next slide. So let me just give you an example of an acoustic outcome in that phase 1 study with children who have Down syndrome. What I'm showing you here are loudness changes on a picture description task. We see dBSPL on the vertical axis, which is an acoustic measure of loudness. Pre-treatment is in white and post-treatment is in gold. And what we see is an increase in overall dBSPL related to picture description tasks, which I just want to point out were not part of the treatment protocol at all. So this is a nice representation of generalization of skills across tasks that were not specifically targeted in treatment. Next slide. In addition, I'm going to show you this slide because it represents listener perception in that same group of children with Down syndrome on percent intelligibility. And so what you see is percent on the vertical axis, again, pre-treatment in white and post-treatment in gold. And we see an increase in listener perception of intelligibility following treatment. This is a trend, but in phase 1 research, a trend is quite good, especially with a small group of individuals. And so we're preparing this particular result for publication this summer. Next slide. So I want to give you an example of a child with Down syndrome pre-treatment. Dr. Fox will play this. This is from a female, age 5 years, and she's saying the phrase, "I need help."
I need help. I need help.
And now this is the same individual saying the same phrase after treatment.
I need help. I need help.
So as you can see, the speech is more intelligible. It's got a very nice level of loudness, and there's a lot more really acoustic cues that the listener can pick up on in terms of what did the child say, and that may also load into then why we see better intelligibility. So the next phase of our work included a group of children with cerebral palsy. All had some type of speech and or voice disorder. They ranged in age from 6 to 10, combination of females and males, all with spastic quadriplegic CP, and a range of severity from mild to very severe. Next slide. This is the first study where we actually looked at some of the respiratory physiology, in addition to the typical perception measures that we've talked about already, and did an attempt to see if we could actually put these children in a scanner and look at their brain before and after treatment. So we also, at this point, added in a structured follow-up where they did a maintenance program of the skills learned in LSVT LOUD for a period of 12 weeks. Next slide. So I'm going to show you one of the outcome variables having to do with respiratory changes pre-post LSVT LOUD. On the left side in the blue are the data from the control or typically developing participants. The upper panel is the maximum phonation duration task, which is part of the treatment target. And the lower panel is sentence repetitions, which are not part of the treatment target, and we use to see if we're getting some generalizability. The first column there, first sets of columns are the time 1 or pre-treatment, time 2 representing immediately after treatment, and time 3 at 12 weeks following post-treatment. And you can see the lung volume initiation, which is the first bar, and lung volume termination, which is the second bar, grouped together by time. And so for phonation and for sentence repetition in the typically developing children, we see no change in where they initiate their speech and where they terminate. On the other hand, to the right of that are the data from our children with CP during the maximum phonation task and during the sentence repetition task. And as you can see from the maximum phonation task, we see an increase in lung volume initiation, the first bars there, from time 1 to time 2, and the maintenance of that initiation from time 1 to that 12-week follow-up. So what that means is that children are going to higher lung volumes after treatment, which is really great because that's a good biomechanically efficient thing to do to help drive or power the sound in a very efficient and healthy way. The same was also found for sentence repetition, where we see an increase in lung volume initiation on that untrained sentence repetition task, again, immediately following treatment. Next slide. We then went on to do what has been our most recent study with a group of children with cerebral palsy including a larger age range from 8 all the way up to 16, a wide variety of speech diagnoses, and a wide variety of cognitive and severity levels. Next slide. And the data that I want to show you from this particular cohort are in addition to what we found in the acoustic and intelligibility and perceptual measures, as well as parent ratings, which were very comparable to all of the previous studies that we've talked about already. So what I'm showing you here is what we call DTI, or diffusion water tensor imaging, and it actually helps us look at white matter fiber tracts, or the electrical circuitry that commands the system from the motor cortex, in this case, out to the respiratory muscles for speech. And so I'm showing you a picture of the left cortical spinal tract, and this is a picture of an individual 12 weeks following treatment. So after that well-documented maintenance practice, we see large increases in cortical spinal tract integrity, meaning that the white matter fiber is more organized, better impacted with proteins. There's a variety of things that are happening there. But the importance is that we've seen evidence now that that 12-week maintenance program is very, very important for these long-term changes in neuroplasticity affecting the structure of the brain itself. Next slide. We also looked at functional neuroimaging pre and post and follow-up LSVT LOUD with the same group of children. And this is a very busy slide, but if you just look at the network on slide in panel G, these are the connections of the various brain regions before treatment started in this group of 9 children with cerebral palsy. When we go to immediately post-treatment, you can see that the network is simplified in some ways. And we think this has to do with strengthening connections that are important for speech and pruning those connections that may be interfering or may not be as important for speaking. And then if you look at panel I, this is after the 12-week maintenance period. You'll see that there's a beautiful connection in the right hemisphere, which is really linking somatosensory feedback loops, auditory feedback loops, and they're feeding into the feedback loops. Thank you for the circle there, Dr. Fox. They're feeding into the networks that produce and regulate speech motor control. So if you think about calibration and you think about what we're working with these children over this intensive period of time, is that internal calibration of feel how that feels, somatosensory, hear how that hears, auditory feedback, and moving that into then the motor output and regulation and feedback systems to the motor output system. This same shift to these right hemisphere networks is what we also see following treatment in other individuals, those specifically with Parkinson's disease. So to see this shift again in this feedback loop in a completely different population has us thinking that there's some validity to this internal calibration that's going on even in these children, which is quite exciting for us. These data are also published, and you'll have that reference below as well as in your handout. Next slide. So to summarize the research end of things, we do indeed see a therapeutic effect following LSVT LOUD in both children with cerebral palsy and motor speech disorders and those with Down syndrome. We also see physiological effects in the direction of improved biomechanical efficiency, and we see neurobiological changes both in the structure of the brain as well as the function. All of these data together support and justify the use of LSVT LOUD in selected children with cerebral palsy and Down syndrome. And we have started to think about potential applications to other pediatric motor speech disorders as well. Next slide. So here are some selected references. Again, they're on your handouts. And the next slide. We just want to thank, first and foremost, the children who work so hard in treatment and their families, as well as the LSVT team, those individuals listed there, and the University of Alberta research team and those individuals listed there. And the next slide. We'll go to Dr. Fox, and she can take you on out from here to the rest of the presentation today.
Great. So for any of you out there who may be looking for LSVT certified clinicians who know how to do this treatment and might be able to offer it to children in your family, children in your practice, we do have a directory on our website. Click Find LSVT Clinicians, and you can locate via zip code. You can call us or email us as well. In a shift to our new website that will be happening soon, we'll actually be able to designate people who indicate pediatric as an area of a practice so that we can help fine-tune searches for LSVT certified clinicians who are actually open to seeing pediatric clients. For those of you who are LSVT LOUD certified or thinking about it, we also like to acknowledge we now have an advanced course. So after LSVT LOUD certification, we have a 3.5-hour online course, Implementation of LSVT LOUD in Pediatric Motor Speech Disorders. Dr. Bullock and I are the faculty, and it takes you through in much greater depth and detail exactly how to do LSVT LOUD in pediatrics. It provides more examples of treatment activities. It also walks through things like documentation, reimbursement, and offers a case study beyond just cerebral palsy and Down syndrome. So just know those resources are available. We always like to remind our audience of our next public webinar that will be held Wednesday, June 20th. The time on the slide I just noticed is wrong. It's 2 p.m. Eastern Daylight Time in the United States, not 8 p.m. And the topic here will be a general introduction to LSVT LOUD and LSVT Big, speech, physical, and occupational therapies for Parkinson's. So if you know of people who are wanting to learn more about LSVT and know very little about it, again, this is a public webinar open to anyone to attend. Please feel free to share that information. So finally, we have a nice bit of time to open the floor to your specific questions. There are two ways that you can, or actually 3 ways you can ask questions. First of all, in your control panel, you have a question box. You can simply type in your question. I will see it in my control panel. We'll ask it aloud, and Dr. Bullock and I can answer that. If you'd like, you can click the little hand that you should also be able to see in your control box. I can call out your name, unmute your microphone, and then you can ask your question out loud. Thirdly, if you think about something after the webinar is over and you go, oh shoot, I wish I would have asked that question, at any time you can email info@lsvtglobal.com, ask clinical questions, and they get forwarded to our LSVT LOUD expert, who then is able to answer those questions for you. And we ask you give 24 to 48 hours for a response, as all of our clinical experts are that because they work full time. So they're seeing patients typically all day, and they pick up answers to these expert questions in the evenings, as well as spending time on their weekends. So I'll open my question pane here and look for our first questions that we have from our audience. And I'll start with this first question here. And Dr. Bullock, I'll give this question to you. And the first question is, what type of practice settings has this treatment been done in? Was it only in the research setting, or is it applicable to people who are children in schools, private practice, rehabs?
Sure. So for the formal studies that you see there, those actually treatment took place in a variety of settings. The child's home, the child's school, and we actually did a number of treatments in a variety of settings during the school day, and that was kind of neat because if there was a teaching aid or a speech aid, they could be very involved in watching us, modeling, helping us do some of the homework activities, carryover activities. We even had observations by teachers when we did it in the schools. It was really a very nice, dynamic environment to do the treatment in. We also did a summer camp where we brought all of the children into a school that was not being used during the summer, and we had multiple treatment rooms going all at the same time with multiple therapists, and that was a really efficient way to get all of the skill sets learned, and then of course maintenance and the occasional sort of what we call tune-ups could happen during the school year. So that's another model that might be considered. In terms of private practice, one-on-one in individual therapist private practices, that's happening across the country, and even perhaps in other countries as well. Dr. Falk can talk about that, but we have therapists who are doing individual and private therapy using LSVT LOUD with these children.
Great, thank you. Next question, just curious about what populations beyond cerebral palsy and Down syndrome have you used LSVT LOUD or would consider it? And so I'll take that question. And right now, in terms of our research hands, cerebral palsy and Down syndrome are the only two pediatric populations that we've done with sort of controlled studies. However, you know, we get to talk to therapists and interact with therapists, as Carol said, around the globe. And we've had a range of different etiologies. Certainly, some therapists have used it with varying types of ataxia, Friedreich's ataxia, or other types of childhood ataxic presentations. We've had some individuals use it for children with autism. And in fact, in that pediatric course, there's a nice case study of a young man with autism treated by one of our experts, Dr. Jessica Galgano, and she walks through the process of working with him. Really, well, he needed an extended amount of treatment prior to LSVT LOUD just to prepare him to be ready for the intensive protocol. We've had other clinicians talk about kids who may have some kind of undiagnosed etiology, but they have soft voice, monotone voice, maybe kind of low tone, kind of floppy kids, and have utilized the treatment with them. So just like we do with adults with populations outside of Parkinson disease, what we train in terms of the training, or teach in terms of the training, is that we would do a period of stimulability testing to see if a child responds to the cue of loudness. If we like what we see there, we'd follow that up with a period of trial treatment, which might be approximately, 1 week of 4 days in a row of treatment to see how the child responds. And then if we like what we see from there, we may continue on with the 4 weeks. If we're not seeing changes, and certainly if things are getting worse, then we gave it a shot, but the treatment, again, may not be the best approach, and we would try something different. Okay, I think we have time for one more question, and Dr. Bullock, I will give this last question to you. And the question is, how is the family involved, and how much are they involved for the success of the treatment?
That's a great question, and it's not any different than successful involvement in other types of more traditional treatment. The nice thing about doing the homework activities, which is when we're not around and those parents have to make sure that they're getting done, or siblings do, is that these activities are designed to be done anytime during the day, during running errands, during other homework practices or other household events like getting ready for school, picking out clothes, a variety of activities. The homework activities and the carryover activities are designed to fit within the normal family routine. And I think that's very important, because families are busy enough, and you won't get good compliance if if we're asking parents to set aside all these extra hours in these quiet rooms to do X, Y, and Z, you know, to make sure homework gets done. So the flexibility of doing homework activities can be as creative as you as the clinician and parents are as caregivers to their children. School environments are also a nice way to do carryover activities and homework practices, and so they may not even require parental guidance in that case. Siblings can also help do these homework activities. I think the thing that I have noticed most is because of the intensive treatment, parents realize changes in their child's voice and communication activities very immediately after you get started, so within that first week. And they are as excited as the children are to see such quick success. And I think by seeing that so early on, you actually increase parental motivation to stick with the protocol and to work with you as a partner in making sure those activities get done outside of the treatment setting.
Excellent, thank you. So with that, we've come to our 1 hour time frame. We thank everybody for joining us today. A few final reminders. If you'd like a certificate to self-report this activity, email webinars@lsvtglobal.com to request a certificate. And when you close out of this webinar, if you can take a few minutes to take our poll, we would appreciate it. If you have any further additional questions, feel free to contact us at any time. So thank you all, and we look forward to seeing you at our next public webinar next month. Thank you.